you once again, and welcome to the Department of Urology, Savai Mansingh Medical College, Jaipur. In its teaching class, today we have antenatal hydronephrosis, which will be presented by our resident Dr. Lokendra and would be moderated by our faculty Dr. R.D. Sahu. So I would request Dr. R.D. Lokendra to go ahead, please, and share your presentation.
Good morning, everyone. Good morning, teachers and my dear colleagues. Myself, Dr. Lokendra Yadav, presenting seminar on antenatal hydronephrosis. My moderator is Dr. R.D. Sahu, sir. Hydronephrosis is the dilatation of the renal pelvis with or without dilatation of the renal calyces. Currently, the term urinary tract dilatation is proposed under the congenital abnormalities of the kidney and the urinary tract. The urinary tract dilatation is the second most common anomaly detected during antenatal screening. Its frequency is about 1 to 3%, and the urological abnormalities incidence in utero is about 1 in 500. Most commonly diagnosed in second trimester, and parental counseling is done for the urological abnormalities. In this PPT, we will have an overview of the grading system, prenatal consultations for specific condition, role of interventions, imaging modalities, differential diagnosis with expected outcomes, risk stratification system. In the definition of antenatal hydronephrosis, it is defined as pelvic anterior posterior APD diameter of more than 4 mm in second trimester and pelvic APD of more than 7 mm in third trimester. The causes of antenatal hydronephrosis can be clubbed as obstructive causes, non-obstructive causes, and the conditions mimicking hydronephrosis. In obstructive causes, we have uretropelvic junction obstruction, uretrovesical junction obstruction, ectopic ureter, ureterocele, posterior urethral wall, urethral atresia, anterior urethral wall, and congenital urethral stricture. In non-obstructive causes, we have vesico-ureteric reflex, primary non-obstructive ureter, megacalicosis, the fetal folds, and the neurogenic bladder. The condition mimic hydronephrosis are extrarenal pelvis, multicystic dysplastic kidney, peripelvic cyst, and the neonatal kidneys. In there is a sonoluscent renal sinus. Then the etiology, the transient urinary tract dilatation have and the incidence of about 50 to 70%. UPGO is about 10 to 30%. UR in 10 to 40%, and the UVJ pattern dilatation is seen in 5 to 15%. And the lower urinary tract obstruction, like posterior urethral and seen in prune belly syndrome, is seen in less number of cases. And about incidence is about 0.1 to 0.5%. In the grading system, the anteroposterior renal pelvic diameter can be used for grading the hydronephrosis into mild, moderate, and severe. In the second trimester, it's of mild variety when the diameter is up to 4 to less than 7 mm, moderate when it is about 7 to less than 10 mm, and severe when it is more than 10 mm. In third trimester, it's of mild degree when the diameter is 4 to less than 9 mm, and moderate when it is 9 to less than 15 mm, and of severe when it is more than 15 mm. ABD can be affected by gestational age, hydration status of the mother, bladder hypertonicity, and the degree of bladder distension. The disadvantage of ABD is the failure to describe pelvic configuration, calyceal dilatation, and the laterality of the findings. In the Society of Fetal Urology is a subjective 5-point grading system that relies on combination of renal pelvis or calyceal dilatation and the integrity of the renal parenchyma. The SFU system has been demonstrated to be predictive of both renal function and the need for surgical intervention in patients with prenatal urinary tract dilatation. In SFU grade 1, the urine barely splits the sinus In grade 2, the pelvis is full and the major calyces are dilated. In grade 3, there is uniform dilatation of the minor calyces and the parenchyma is not involved. And SFU grade 4, there is a compromise of the renal parenchyma. Renal parenchyma may appear thin. In the urinary tract dilatation grading system, this is a system consists of 6-point template that combines two of the most common system employed, that is APD and SFU, and includes both objective and subjective evaluation. In effort to mitigate postnatal over-testing, the UTD working group established a normative for postnatal APD which parallel those observed for the prenatal period. An APD cutoff of less than 10 mm in the postnatal period was selected in the absence of calyceal or ureteral dilatation and felt to represent non-pathological renal pelvis dilatation. It's a standardized reporting technique and it includes all of the urinary tract. The normal values under UTD classification is anteroposterior diameter of less than 4 mm up to 26 of weeks of gestation and up to 7 less than 7 mm in more than 28 weeks of gestation, and in the postnatal period is less than 10 mm, and there is absence of any calyceal dilatation and the parenchymal thickness and appearance should be normal. The bladder and ureter should be normal and there should be no unexplained oligohydramnios in the prenatal period. The risk stratification for prenatal urinary dilatation, it's grouped in low risk and high risk. In the urinary low risk group, the APD diameter is less than 7 mm in up to 27 weeks and up to 7 to 10 mm more than 28 weeks. And the high risk, if the UTD with increased risk is APD of more than 7 mm up to 27 weeks and more than 10 mm after 28 weeks. In this, the low risk group, the USG is recommended at the 32 weeks, and in the increased risk group, the USG is advised every month in the prenatal period. In the prenatal management part, the termination of pregnancy for antenatal hydronephrosis is not recommended except in cases of a severe oligohydramnios or if there is any other major structural anomalies. The diagnostic and therapeutic interventions for prenatal hydronephrosis should be done at specialized centers and in case of a lower urinary tract obstruction and or oligohydramnios. The prenatal intervention for lower urinary tract obstruction can be early delivery of the fetus and can be as a fetal shunting or fetal surgery. The criteria for identifying the candidates for fetal intervention are in the ultrasound findings. The favorable criteria are equidistant the renal parenchyma and there should be no other systemic abnormality. The karyotype should be normal and on urine, the serial electrolyte should be in the decreasing trend. At least 3 readings of the urine examination are done for this. In this, the should be decreasing sodium, calcium, hypotonicity, beta 2 microglobin, and protein levels in the fetal urine. In the indications, if for in utero urinary decompression, if there is any evidence of bladder outlet obstruction as seen as USG suggestive of dilated bladder with hydronephrosis. There should be normal karyotype, no systemic anomalies of other system, a male fetus, singleton, and the early oligohydramnios that is of early onset, is less than 25 weeks, the non-cystic kidneys and favorable urinary indices, and they should be informed consent of about the risk of partial treatment and of the complications of the procedure. Prenatal it is done in the mid-second trimester, and there are risk of fetal loss, choriamnitis, and preterm labor. There is improved perinatal survival in case of severe obstruction. However, the long-term renal outcome and mortality is still controversial. The Vesico-amniotic shunt or the RODECK shunt, in this, there is a placement of the shunt between the fetal's bladder and the amniotic fluid. In the fetal bladder is initially reached with a needle and a large bore introducing sheath is passed into the bladder. Within this sheath, the shunt is passed and a double pigtail shunt with holes in each and following free drainage between the bladder and amniotic space is placed. The complications of insertion of vesicoamniotic shunt can be herniation of bowel loop or the strangulation of umbilicus. In the fetal cystoscopy, there is direct visualization of the cause for lower urinary tract obstruction. It improves the ability to obtain the fetal diagnosis, and there is an opportunity for a directed intervention. There is no dependence on a functional device, and a suprapubic access allowed the use of an anti-arc laser to ablate the valve in an anti-grade manner. In this, there is a visualization of the posterior urethral valve while doing a fetal cystoscopy. Here is a video of placing of amniotic vesicoamniotic shunt, RODECK shunt in a fetus.
To place a shunt, we do that in the operating room.
In utero shunting is performed as an outpatient procedure in the STU, which is our special delivery unit. Moms will arrive and will be prepped for the procedure, will receive anesthesia services.
The patient gets sedation and is comfortable through their IV. We use local anesthesia, so they're numb and they don't feel the procedure. The sedation that mother gets is transmitted across the placenta, so the baby does get some of that sedation as well. We numb the skin, we make a tiny 5mm incision through the skin, and then we direct this needle that will eventually be used for passing the shunt through the maternal abdomen, through the wall of the uterus, and into the fluid space immediately next to the fetal abdomen. Once the tip of the needle is in appropriate position between the pubic bone and the umbilical cord, then it has to be carefully inserted through the fetal abdomen and into the bladder. Once in the bladder will start to leak fluid around the needle. So you have to move swiftly, but you have to move very precisely. The shunt has to be loaded into that needle. The shunt itself comes in the double pigtail configuration.
So the short you end on the outside of the abdominal wall and one on the inside of the bladder.
Has to carefully be straightened out so that it can be passed into the needle. It's a plastic that has memory, and so it will recoil to its original configuration. Once you're outside the fetal abdomen, you now have to again pull the sheath back a bit, turn it at an angle away from the fetus, and then push the other pigtail out into the amniotic space. So the hope is that it will lie flat against the fetal abdomen. After the shunt is placed, the mom comes out to her room on the special delivery unit where we watch her.
So, vesicoamniotic shunt versus fetal shunting. In conclusion, both vesicoamniotic shunt placement and fetal cystoscopic surgery demonstrated a clear survival advantage. How the fetal cystoscopic ablation demonstrated an improvement in both 6-month survival and renal function in posterior urethral wall. A report from the SFU endorsed a severity of disease classification system developed by Ruano that was indexed to perinatal and renal outcome. The purpose was an attempt to better identify patients that may benefit from fetal intervention. The proposed classification by Ruano et al. For prenatal lower urinary tract obstruction can be grouped as stage 1, stage 2, and stage 3. In stage 1, the amount of amniotic fluid echogenicity and the renal parenchyma and the fetal biochemistry is normal, and the fetal intervention is not required. In stage 2, there may be oligohydramnios and the kidneys may be hyperechogenic, and there are favorable urinary biochemistry, fetal biochemistry, and the fetal intervention is indicated to prevent pulmonary hypoplasia and severe renal impairment. In stage 3, the fetal intervention may be indicated to prevent pulmonary hypoplasia, but the postnatal renal impairment is required further studies. The disease can progress from stage 1 to stage 3 and then to stage 3 during pregnancy. The algorithm for prenatal management, the unilateral or mild hydronephrosis, the USG is done at the third trimester, and the postnatal USG is advised at 3 to 7 days of life. In bilateral severe hydronephrosis or unilateral hydronephrosis, serial USG is advised in every 4 to 5 weeks and followed by a postnatal USG at 48 hours of the after delivery. And when there is a systemic malformation along with hydronephrosis, the child is referred to a specialized center. In the postnatal evaluation, the renal imaging studies are renal ultrasound for seeing any resolution of urinary tract dilatation, voiding cystourethrogram, renal scintigraphy, and magnetic resonance urography. In the USG, it is a simple to radiologist, easy to reassure in milder cases regarding resolution, and it can be used for extent of evaluation and follow-up of the patient. It clubs different etiologies and together. There is a need for intervention. Need for intervention is not predictive and has to be decided on each diagnosis severity. In the postnatal presentation on ultrasound, if it's interventional renal pelvic diameter is 10 to 15 mm, then it is in low risk group. If it is APRD of 15 mm, then it is an intermediate risk group, and if it is more than or equal to 15 mm, then it is into the high risk group. The wording cystogram is indicated in the unilateral or bilateral hydronephrosis if it's of SFU grade 3 or 4 or APD is more than 10 mm, or if there is any evidence of ureteric dilatation, or if any patient with antenatal hydronephrosis who develop UTI. It's done within 24 to 72 hours in a suspected case of lower urinary tract obstruction. And in other cases, it can be done up to the 4 to 6 weeks of age. We use radiation as minimally as possible. And in it, the non-balloon catheter and the cycling of study increases the reliability of the study. The renal scintigraphy is indicated in moderate to severe unilateral bilateral hydronephrosis who do not show any vesico-ureteric reflex, and infants with hydronephrosis and dilated ureters and absent VUR, and in patient with VUR with worsening hydronephrosis to look for any coexisting PUJO. And it is used to assess renal perfusion and the glomerular function of each kidney is assessed. If there is any structural abnormalities, and the drainage of the collecting system is seen, and it is used for guide for intervention when there is decreased differential function of less than 40% and the TF is more than 20 minutes, and there is a significant retention on delayed imaging. It's the drawback of renal scintigraphy that it does not provide any anatomical details of the system, and it is preferably done at the 6 to 8 weeks of life. Renal cortical transit time. If in a dilated system, the dilated system will necessarily have a slow rate of clearance of radioreceptor despite the lack of functional obstruction, as the system has to fill before the drainage is appreciable. Therefore, dilatation in a growing kidney on USG is not a very reliable indicator for the presence of obstruction. Conventionally, the T-half values or the presence of any obstructive curve on a urogram or a differential function of less than 40% have been taken as an indicative of obstruction. However, many studies have questioned about the usefulness of these criteria. One such parameter has been the cortical transit time estimated on the renogram. It is defined as the time taken by the tracer to pass from the cortex to the pelvic-calyceal system, and this aims to review the usefulness of the cortical transit time to differentiate obstructive from non-obstructive dilatation of the PCS. In the renogram, here is the image showing the normal cortical transit time of less than 3 minutes and a delayed cortical transit time of the more than 3 minutes. And magnetic resonance urography, its role is not clearly defined. It is required when there is a need of anatomical detail or the renal function to aid in operative planning, like in having a duplex system, tracheal ureter, and the rare situation like VUJ with PUJO. Management for postnatal urinary tract dilatation. If it is of urinary tract dilatation is of low group, then the with a SFU grade 1 or 2, the complete resolution has been demonstrated to occur in most patients between 24 and 48 months, and it is reasonable to obtain the second ultrasound between 3rd to 6 months of age, and there is uniformity in ROT recommended for prophylactic antibiotics or avoiding cystourethrogram for those under low risk group. In the intermediate risk group, it is a less defined, and the recommendation for prophylactic antibiotic and avoiding cystogram is left to the description of the treating physician. In the high risk group, this group is to be at most risk for UTI, deterioration of renal function, and the need for any surgical intervention. The use of prophylactic antibiotics, lower urinary tract imaging, and the renal scintigraphy are recommended in the high risk group. Consideration for severe bilateral urinary tract dilatation. After delivery, it is important to promptly compress the unibladder and to begin antibiotic prophylaxis and proceed with a prompt evaluation of the urinary tract to determine its etiology. And the urinary tract infection, its incidence is about 8 to 20% in case of antenatal patients with antenatal hydronephrosis. The degree of kidney dilatation is a predictive of risk for UTI in patients with prenatal urinary tract dilatation. Uniformity exists in identifying female gender, high-grade kidney dilatation, that is SFU grade 4 and 3, and uncircumscribed status as factors that are associated with increased risk of UTI. Role of prophylactic antibiotics its role is not clearly defined. Current recommendations are restricted the use of prophylactic antibiotics to those at increased risk of UTI. Antibiotics used are amoxicillin and third generation cephalosporin in newborn, and the trimethoprim and the natroprin can be advised after 8 weeks. Recommendation for the major causes of UTD, the urinary and the transient urinary tract dilatation, which is seen in about 40 to 70% of the patient. It has the more than up to 90% resolution for SFU grade 1 or 2 at patient at 12 and 18 months. Here is the algorithm for the postnatal management. In this, if initial scan is done in the first week, and if the repeat scan is done at the 4th and the 6th week. If there is no hydronephrosis and SFU grade is 0, there is no further intervention required. In case of mild hydronephrosis, that is without ureteric dilatation, and SFU grade 1 or 2 or APD of 7 to 10 m, then ultrasound is needed at the 3rd to 6 months and serially followed until there is any resolution. In moderate and severe hydronephrosis, if SFU grade 3 or 4 and APD is more than 10 mm, the maturing cystourethrogram is advised, and if there is no VR, diabetic urinography is advised, and if there is VR, then antibiotic prophylaxis is advised according to the grade. And if on MCU there is lower urinary tract obstruction, then the patient is referred for surgery. And when to intervene? In a case of posterior withdrawal, straight away for the surgical intervention. In VUR, it is delayed, and in VUJ, it is questionable. The recommendations for doing surgery in the case of a uretropelvic junction obstruction, if there is increased APD and urinary dilatation on serial ultrasonography, there is a decreased differential function of less than 40%, or the progressive decrease of more than 10% from the previous study, delayed drainage curve, or there is an increased retention of radio tracer on delayed upright imaging on a MAC3 renal scan, or if the patient is symptomatic, having pain or a palpable lump. Early pyeloplasty can be restricted to a modest number of infants in whom there is impaired renal function. In those managed expectantly, there is a small but significant risk of permanent loss of renal function. Can we predict which case will lose function during follow-up and preempt pyeloplasty to prevent permanent loss? For this, hydronephrosis severity score is there, and it compromise of the SFU grading, drainage pattern on urogram, differential renal function. It is graded from 0 to grade 4. Its minimum score is 0 and maximum score is 12. It is of mild when it is up to 4, moderate when it is up to 5 to 8, and severe when it's 9 to 12. Hydronephrosis CVT score can be a tool to predict the need for surgery. Deterioration was noted in those with HS hydronephrosis CVT score more than or equal to 9. Pelvis cortex ratio, it is a sonographic marker for PUJO in children. The pelvis cortex ratio can be used for follow-up following pyeloplasty in children. Take-home message: the antenatal hydronephrosis is the most commonly urological abnormality detected antenatally. It's transient in about 41 to 88%. Antenatal counseling should be done for the hydronephrosis, and the fetal intervention role is controversial. The patient must have a regular postnatal follow-up. Interventions may be required in 4 to 15% of the patient.
Thank you, Dr. Lokendra, for that quite good presentation. And I can see we have Dr. Anil Takwani with us, Dr. Amil Bhatt Sahab with us. So we will just call them. So first of all, Dr. Bhatt, please give your comments.
Okay. No, I think it was a brief summary and a nicely presented seminar. Almost all aspects they have taken up. They, as far as fetal surgery is concerned, only a few centers in the world is doing. And none of the center in India is doing at present. And postnatal follow-up, that is important. And there is some gray area of this moderate risk. Otherwise, the things are well defined. Low risk has to be observed. High risk, the surgical intervention is to be taken. And especially the hydronephrosis surgery is to be taken around, to be done around 3 months.
Thank you, Dr. Bhatt Sahab. Dr. Takwani, please unmute yourself and
good morning.
Thanks for coming.
Yeah.
Thanks for joining us, both of you.
Yeah. Good morning, and
really
thank you very much,
privileged.
Shivam, for inviting and your zeal for teaching. Excellent morning seminar and excellent presentation by the Dr. Lokendra. He summarized almost everything. We'll be having a couple of questions. Once you will raise the hand, we'll ask him or expert sitting there some questions. Now, regarding fetal intervention, when I presented this particular topic in the USI seminar, USI Smart Learning, when I was inquiring, there are a couple of centers in South India. They are doing fetal intervention, including Vesico-amniotic shunt. In Pondicherry, which exact institute I right now not recollecting, but couple of centers they do, and they says that they have a fairly good outcomes, so it is not reported. And Lokes has rightly said, it is really controversial area, and it requires a lot of scrutinization before anybody indulge into the this fetal intervention. Rest other, I have some questions, Shivam, if you have.
Yes, please go ahead.
Yeah,
please.
Can I ask now?
Please,
Lokes,
go ahead.
Lokes, you said about something about the drainage curve, and you also incorporated drainage curve into one of the prognostic factor which can help in deciding whether to operate UPJO like obstruction or not. What are the limitations of drainage curve, specifically in infants? Because nowadays, see, you talked about the antenatal hydronephrosis. So now you are talking about the immediate postnatal period, that is a neonate and infants, right? So tell us that what are the limitations specifically of a diuretic curve in the infants?
Limitations are in it, the patient should be adequately hydrated, and in prematurity of the infants, and gross hydronephrosis if there, poor functioning kidney, And if positioning of the patient, hypertonic bladder.
So many variables are there, right? So many of the times I have seen. See, you told us that most of the time the interventions require in almost 15% cases. Absolutely excellent not to finish your presentation. But in practice, if you will look around, right, we are exceeding this figure almost 3 to 4 times. Just sometime taking decision on the diuretic curve, right? And but we have to keep, as you said, many variables in specific hydration, gravity, fullness of bladder, because we don't put catheter in routine, right? Other than these simple variables, we have a variables like reservoir effect, as you said, the gross hydronephrosis, some reduction in the renal functions. So many variables are there for the diuretic curves, which is to be mentioned as well as kept in the mind, not to exceed in our interventions. Now, tell me another thing is that as you are putting so much of attention on the degree of dilatation or amount of dilatation, where exactly you see for this APD? Where exactly, on which plane you look at it? Yeah.
In that transverse plane in the anteroposterior diameter is seen, sir.
Where exactly? You are right. But where you will see? You will see where?
It is seen in
at the renal hilum, right? At the renal hilum. See, because you only mentioned that extra-renal pelvis can misguide us or overestimate it, right? So if any measurement done in the other than the you can say transverse plane, or you can and not seen at the hilum, right? So anteroposterior diameter in transverse plane and at the hilum. That is to avoid the exaggeration of the diameter measurement. And one more question, and thereafter, if I give an opportunity, I will ask what is the you can say that argument which satisfied you for a transient hydronephrosis? Means how will you explain the transient hydronephrosis? In short, there is an entity of a transient hydronephrosis which you nicely mentioned. If you look at the etiological classification which were published in guideline before 2000, right? Transient hydronephrosis was not there. It was started with the PUJO like obstructions in almost 50+%. But our understanding improved with the excellent work of few people. And in 2010, when the revised guidelines were posted in most of the journals, transient hydronephrosis, which notice on the top. Now, can you explain the physiology behind the transient hydronephrosis? By pathophysiology, or you can say physiology. Yeah.
Sir, there is a transient PUJ obstruction which usually resolves when the
that can be transient, UPJ, VUJ, both can be transient.
Sir, it improves when there is a fetus grows. It can be because of the kinks of the ureter or
that is anatomical. Anything else? Means suppose there is a child, you said that there is a grade 2 hydronephrosis, SFU, or grade 2 to 3. You put the patient on an observational protocol, rightly said, right? And you see by the 1 year or 1.5 years, as Braga said, that in this many numbers of patients, it spontaneously regress or disappear. Can you explain this? What are the possible explanations? Why it happens so?
Maturity of the pelvic calyces of the renal system.
What matures? Pelvic calyces system matures, or anything, something else matures?
The ureteral lengthening.
So possible explanations are like this. I think Sivam and Abilal Bhatt and some other experts can comment on that. But this is the work which was, I'm just trying to recollect the name. But what happens? The GFR is not matching to the adult GFR till the age of 2 years. It gradually increases with the passage of the time. At the 2 month, at 4 month, at 8 months, and it matches to the adult GFR by 2 years. So increase in GFR increase the urine output. And second thing, the pelvis compliance is quite high in the initial period. But over a time, compliance of the pelvis is reduced, pelvis wall. renal pelvis wall reduces, right? So together these increase in output as well as reduction in the pelvic compliance overcome the resistance at the upper level of ureter, which is there in the UPJO or at the VUJO. This resistance is overcome, and that is how we can explain the transient hydronephrosis, spontaneous regression. Yeah. So thank you for your question, the answers. You have done beautiful job, and I wish many congratulations to you for this beautiful presentation and best wishes for your future.
Thank you, Dr. Takwani, for those wonderful questions, and definitely those were really enlighten our residents also, and those might be who might have joined us today. So
your enthusiasm is superlative. Once again,
thank you. Dr. Bhatt, if you want to comment on these questions, any of these, would you like to comment? Yes, please go ahead.
Dr. Takwani has explained very nicely. So you see, maturity of the nephrons to have the concentrating ability takes time. So that earlier stage, the system is not coping with that one, and with the maturity of the nephrons, the concentrating ability also increases, and then they slowly regresses the dilatation.
Right. I think, yes, all these factors are very important. One, the maturity of the kidney, the maturity of the pelvic compliance, then probably the pacemaker system also, which helps to propel the urine from pelvis into the ureter. Probably that also gets more mature as the child grows. So all these factors probably helps in the resolution of the hydronephrosis. And that is why I think we should not jump on doing any intervention in these patients unless it is really indicated.
And the approach should be conservative one, rather than going for surgery and then choose the patient and go ahead for surgery.
Right. And closely monitoring these patients and follow up these patients.
If you permit a 1 minute comment on CT,
yes, please go ahead.
Transit. Yeah, this cortical transit time, which we don't get exact calculations in the machine in most of the cases. It was there in the Justlock Hospital on too much of insistence of our late Professor S.S. Joshi. And he worked a lot on this. We have a beautiful publications. Now, this is for residents. What is difference between the split function or diuretic curve and the CTT? Now, diuretic curve is an excretory function, and which is affected by many variables other than the obstruction. It can be reservoir effect, hydration, gravity, bladder condition. All those things are affecting output, maturity. But the CTT is a secretory function. It suggests secretory functions. It is the time taken by the radioisotope to reach to the pelvic LSS system. If it is reached in within 2 to 3 minutes in uniformity and in an adequate amount in compared to the opposite kidney, which is the crude way to judge, but still it guides a lot because it is not much affected by the other variables. So it is not the sacrosanct, but we have to keep watch on this CTT. And diuretic renal scan, this diuretic curve probably not have any role to play, at least in the infants in decision making. It can be just additional parameter when we explain to the parents that this is how it is looks like. But this is what I published and presented in the year 2017, and which was well appreciated. Thank you.
Thank you, Dr. Takwani. And I just remember Dr. Ganesh Gopal Krishnan's presentation also on hydronephrosis, where he says it still remains a dilemma. How these kidneys, because we see many patients who come in adulthood, maybe after 50, 60 years of age with the same kind of dilatation, which probably has not deteriorated. So still it remains a dilemma, and we need to know much further. And what Dr. Lokendra also said about the two scoring system, one was the hydronephrosis severity scoring, which may help in preempting that which patient should be intervened, and plus the pelvic cortical ratio that he said probably might help in many of these patients to whether they need to be intervened or not. So thank you, both of you. For the benefit of residents, I will just briefly summarize this antenatal hydronephrosis. Antenatal hydronephrosis, as we know, the incidence in various studies could vary from 0.6 to 4.5%. And males are twice more affected than females. And the bilateral hydronephrosis could be in around 20 to 40%. And we know the transient hydronephrosis is usually called when the RPD, that is the renal pelvic diameter, is less than 6 millimeter. So this diameter can be measured at the 12th week, as early as 12th week. So we need to follow up these patients, and if the diameter is more than 4 millimeter, then we need to do a serial ultrasound in these patients. And we see that if the dilatation is more than 10 millimeter at the third trimester, these are the patients which need further evaluation postnatally and need to be followed up. And about the measurement of the severity of hydronephrosis, we started with the renal pelvic diameter, which was mild, moderate, severe. Then we went into SFU grading, which included the renal parenchymal thickness also into the diameter also. And then we went on to doing UTD classification, which was given by a panel of urologists, nephrologists, and radiologists. But also the echogenicity of the parenchyma, of the bladder, and ureteral abnormalities. And all these were taken into consideration to understand the severity of the UTD, that is urinary tract dilatation, and which patients actually require monitoring and intervention. So UTD, they were divided into 3 grades. One is the mild, moderate, and severe. That's a low risk, intermediate risk, and high risk. Low risk usually doesn't require any intervention. Intermediate and high risk would require follow-up and may require intervention. And about the treatment part, many of these patients, usually the termination of pregnancy in these patients are not recommended unless there is a severe kind of bilateral hydronephrosis with renal dysplasia, with oligohydramnias, and all these factors which tell you that this patient may not survive postnatally, or even if he survives, his days would be very few and he would require a very early renal transplant or renal replacement therapy. Then probably you may require a termination of pregnancy, and particularly these patients may also require an investigation regarding their karyotyping and any syndromic manifestation. We know in Down syndrome, the hydronephrosis, the incidence and prevalence of hydronephrosis is more. So many of these patients would require testing for trisomy 21. And if there is a syndromic manifestation, then probably they may require a termination of pregnancy. Otherwise, sometimes we may have to do a premature termination of these pregnancy. And then the interventions of regarding the fetal cystoscopic ablation of valve and Vesico-amniotic shunt, as Dr. Lokendra said, has to be balanced with the risks involved in these interventions, because many of these patients would end up with fetal loss or some other kind of problem later postnatally. So as Dr. Takwani said, there are 2-3 centers in our country also which are doing Vesico-amniotic shunting, and so we need to work upon on these procedures before these become kind of a recommendation for kind of mild to severe, moderate to severe hydronephrosis antenatally. So this was in brief the summary. Thank you everybody. And thanks my residents, thanks my faculty, and special thanks to our experts, Dr. Amilal Bhatt and Dr. Anil Takwani, who on a very, very short notice, that is maybe about 10-15 minutes only, they joined us in our class. And thank you very much. Thank you, Dr. Anil. Thank you, Dr. Amilal Bhatt. Any last comment? And then we'll wind up.
Given opportunity, I will attend your class more frequently.
Thank you.
Thank you. Thank you. Thank you, Dr. Bhatt. Any last comment?
Beautiful.
Thank you. Thank you.
Thank you. Thank you. We see Dr. Kim also there, Dr. Faizan, many of joining. Thank you. Dr. Kim, would you like to give a comment? Dr. Kim? Okay. Thank you. Thanks all residents. Thanks all faculty. Have a good day.